Welcome to Psych Talk for primary care providers, where our esteemed faculty members will provide you with invaluable insights to seamlessly integrate into your daily practice. Today, we will talk about post-traumatic stress disorder with Dr. Alyson Myers.
Hello, my name is Dr. Alyson Myers. I'm the Associate Chair for Diversity, Equity, and Inclusion at Montefiore Albert Einstein in the Bronx. I'm also an Associate Professor at the Albert Einstein College of Medicine. Today, I'm going to talk about post-traumatic stress disorder. Post-traumatic stress disorder, or PTSD, impacts about 5% of Americans yearly. PTSD is associated with a wide range of problems, including difficulties at work, social dysfunction, and physical health problems. Any event that is traumatic also has the potential to lead to PTSD. We as individuals all have a different capacity for what we can define as a trauma. Trauma can be from ongoing abuse in childhood, discrimination such as racism, sexism, homo or transphobia, war, human trafficking, or abuse in intimate relationships as an adult. Per the DSM-5, the trauma must be the result of one or more of the following scenarios in which the individual directly experiences the traumatic event, witnesses the traumatic event in person, learns that the traumatic event occurred to a close family member or close friend, with the actual or threatened death being either violent or accidental, experiences firsthand repeated or extreme exposure to adverse details of the traumatic event, not through media, pictures, television, or movies, unless work-related. For some people who are exposed to trauma, they do not develop PTSD. Resilience is more likely if one has good social support, mindfulness of their stress response to trauma, coping strategies for dealing with trauma, and preparedness and ability to respond to upsetting events as they occur despite feeling fear. Distrust, paranoia, and fear are often a part of the trauma response for persons with PTSD. This may stem from childhood abuse or neglect, or can occur later in an intimate adult relationship. If some of the familiar abusive or neglectful patterns are reenacted by an adult friend or significant other, it can trigger a trauma response, such as dissociation or deflection to avoid the discomfort. As a result, persons living with PTSD may avoid conflict, push away, shut down, or be abusive themselves to the people that are closest to them. There is also often a comorbid depression, panic disorder, or substance use disorder in persons with PTSD. The DSM-5 has 4 distinct categories of criteria. They are described as reexperiencing, avoidance, negative cognitions, and mood and arousal. At least 1 reexperiencing symptom, 1 avoidance symptom, 2 arousal and reactivity symptoms, or 2 cognition and mood symptoms must be present. Reexperiencing symptoms can include, but are not limited to, experiencing flashbacks, such as reliving the traumatic event, including physical symptoms such as a racing heart or sweating, having distressing thoughts, experiencing physical signs of stress. Avoidance symptoms can include, but are not limited to, staying away from places, events, or objects that are reminders of the traumatic experience, avoiding thoughts or feelings related to the traumatic event. Avoidance symptoms may cause people to change their routines. Arousal and reactivity symptoms include being easily startled, feeling tense, on guard, or on edge, having difficulty concentrating or falling asleep, engaging in risky, reckless, or destructive behavior. Cognition and mood symptoms include having trouble remembering key features of the traumatic event, or having negative thoughts about oneself or the world, losing interest in enjoyable activities, or having feelings of social isolation. Cognition and mood symptoms can begin or worsen after a traumatic event. They can lead a person to feel detached from friends or family members. So, how is PTSD treated? Treatment needs to address both the traumatic situation and the symptoms of PTSD. Trauma-focused therapy targets PTSD symptoms and emphasizes a few key components, including learning skills to help identify triggers and manage symptoms. Some examples are cognitive processing therapy. This allows one to learn how the trauma changed their thoughts and feelings. Changing how you think about the trauma may change how you feel over time. Another example is prolonged exposure, in which one learns how to process their trauma until the memories are no longer upsetting, thus decreasing their avoidance of the situation. Medications. Currently, only sertraline, also known as Zoloft, and paroxetine, also known as Paxil, are FDA approved for PTSD. These drugs are both selective serotonin reuptake inhibitors. Sometimes venlafaxine, which works on both serotonin and norepinephrine, is used off-label. A patient with PTSD needs to be assessed for other conditions, such as bipolar disorder. We know that if an SSRI is used in someone with bipolar disorder, it can sometimes induce mania. So it's really important to rule out that the patient does not have comorbid bipolar disorder. Another thing to keep in mind is that SSRIs can cause GI dysfunction and side effects, as well as sexual dysfunction. Another medication that can be used off-label is prazosin, as it can help with nightmares. Prazosin is an alpha-1 blocker which crosses the blood-brain barrier, reversing the effects of alpha-1 stimulation, which can increase the stress response and decrease REM sleep. Therefore, these medications are not helpful for initial insomnia. Also, it's important to screen for alcohol use disorder because patients who are using alcohol to help them sleep will not benefit from using prazosin. Start at 1 milligram and titrate to achieve improvement in symptoms. Doses can be as high as 15 or 20 milligrams at bedtime. Providers can use the past week version of the clinician-administered PTSD scale, also known as CAPS, to assess improvement in symptoms over the past week. For patients given prazosin, side effects can include orthostatic hypotension, weakness, dizziness, tachycardia, and in rare instances, priapism. Prazosin will help with nightmares. It is also off-label use. It is an alpha-1 blocker which crosses the blood-brain barrier, reversing the effects of alpha-1 stimulation, which can increase the stress response and decrease REM sleep. Therefore, it is not helpful for initial insomnia. Also, it is not helpful if the patient has an alcohol use disorder, so make sure to screen for that. Start at 1 milligram and titrate to achieve improvement. Doses as high as 15 or 20 milligrams have been used. Providers can use the past week version of the clinician-administered PTS scale, also known as CAPS, to assess improvement in symptoms over the past week. Side effects include orthostatic hypotension, weakness, dizziness, tachycardia, or in extreme cases, priapism. One other thing that you can consider is an FDA-approved device called Nightmare. Nightmare is not meant to be used as a standalone therapy for PTSD. It should be used for medications. You use it in conjunction with your Apple Watch. The device is able to detect when you're having a nightmare, and it'll vibrate in order to help to end the nightmare early. So that was an overview about PTSD, its causes, its symptoms, as well as treatments for PTSD. Thank you.